Imagine walking into a car dealership today, right?
Yeah.
You pick out a solid, reliable $20,000 sedan.
Right. Just a totally normal purchase.
Exactly. So you go to the financing office, and the dealer looks at you and says, great, sign right here. Go ahead and take the car home. We will mail you the actual price of the vehicle in about 3 months.
Which is just wild to even think about.
It is. And the dealer adds, it might be $5,000 or it might be $80,000. It really just depends on who your boss is, what kind of plastic card is in your wallet, and honestly, how our billing department feels that day.
Yeah, you would literally laugh in their face and run out of the building.
Run for the hills, I mean. But the crazy thing is, tomorrow morning, millions of Americans are going to do exactly that at their local hospital.
Yeah, it's the only major sector of the entire economy where the consumer is legally bound to pay for a service before anyone will tell them or even can tell them really what it actually costs.
It's completely baffling. So, welcome to another deep dive. Today, we are taking a massive stack of research, historical data, and economic analysis, and we're pointing it all at one massive topic.
The American healthcare system.
The big one. And the mission for this deep dive is actually incredibly clear. We are going to completely dismantle the biggest misconceptions about why your medical care is so expensive.
Right.
We're going to track the history from the days of quote-unquote simple medicine, unpack how the rivers of money actually flow through these towering institutions, and finally explain exactly why being a patient today feels so incredibly frustrating.
And crucially, what it would actually take to fix it.
Yes. So, okay, let's unpack this. Because I promise you, if you're listening to this, by the end of our conversation, that bewildering medical bill sitting on your kitchen counter right now, you know the one, with the crossed out numbers and the weird adjustment codes.
Oh, yeah, we all have one.
It is finally going to make structural sense. But to really understand this, we have to establish the sheer scale of what we're talking about right off the bat, right?
Yeah, absolutely. We have to realize we are not examining a single broken machine here. We are looking at a $5.3 trillion political economy.
Trillion, with a T.
With a T. I mean, healthcare consumes roughly 18% of the entire United States gross domestic product. It is literally larger than the entire economies of most developed nations.
It's just staggering. But before we get to the math of the modern hospital bill and all those trillions, we have to clear away the false narratives we constantly tell ourselves.
The myths, yeah.
Right. I like to call the biggest one the cartoon villain myth.
Oh, that is everyone's favorite parlor game.
It really is.
Because when a system is this opaque and this frustrating, human nature just demands a single bad actor to blame.
Yeah, what a bad guy.
Exactly. Depending on your personal philosophy, you might point the finger at greedy insurance companies denying care.
Right, or someone else blames massive hospital monopolies charging $20 for a single aspirin.
Yeah, or another person blames big pharma, and another group blames government interference or, private equity.
It's exactly like a giant game of Clue. Everyone is absolutely convinced they know exactly who did it in the library with the candlestick. Like, it was the pharmaceutical CEO with the patent extension.
Exactly. And the appeal of those explanations is obvious, right? They're simple, they give you a clear enemy, and they are emotionally satisfying.
But I'm guessing the reality is a bit more complicated.
It is far more sobering. The American healthcare system is not a machine that was perfectly designed and then hijacked by one specific villain. It is fundamentally a pile of bargains.
A pile of bargains? That is such a fascinating way to frame it.
It's really the only way to understand it. These bargains were made at vastly different times in history, for entirely different reasons, and under completely different political and economic pressures.
So nobody sat down in a room and designed this?
Nobody. And the wild part is, every major institution in the system can actually tell a partially true story about why it is forced to behave the way it does.
Like they all have an alibi.
Exactly. Yeah. The hospitals will point to their massive labor costs, their 24/7 emergency room obligations, and the fact that Medicare underpays them.
Okay, fair.
Then insurers will point out that hospitals have consolidated into local monopolies that demand outrageous rates.
Also true.
And the drug manufacturers will point to the massive financial risks of researching and developing a new molecule.
So everyone is just pointing fingers in a circle, and the crazy part is, they are all technically telling the truth about their specific piece of the puzzle.
Yes, all of those claims are at least partially true at the exact same time. The core insight here is that the system isn't solely defined by greed, though. Let's be absolutely clear. Aggressive profit-seeking is plainly present.
Oh, for sure.
But the system is primarily defined by its incentive architecture. Every major player has adapted to survive inside a highly specific ecosystem of payment rules, ownership structures, and administrative complexity.
They are acting rationally according to the rules of the game they are trapped in.
Precisely. They don't need to be cartoonishly evil to produce a terrible outcome. They just need to follow the incentives.
Man, that really shifts how you look at it. But this leads perfectly into the second part of this trap, which is the nostalgia factor.
Oh, the good old days.
Right. I hear this all the time. People say, medicine used to be so simple and affordable. What happened to the good old days when the local family doctor just came to your house with a black leather bag and charged you a few dollars?
Yeah, that is a massive trap. We really have to look at the sobering reality of those good old days. Medicine in the late 19th and early 20th centuries was simpler, yes,
Uh-huh.
but it was simpler for one overriding reason.
Which is?
There was significantly less medicine.
Ah, right. I mean, if you go back to the 1920s, diagnostics were basically a stethoscope and a thermometer.
Exactly. ICUs didn't exist.
All right,
If you got a serious systemic infection or a complex chronic illness, well, the treatment often consisted of bed rest, and the outcome was often permanent disability or, death.
So simpler did not mean fairer.
And it certainly did not mean more secure. It often meant more direct exposure to catastrophic, fatal risk. A simpler health system is naturally going to be vastly cheaper if its primary feature is that it simply lacks the capacity to save your life in a crisis.
So saying healthcare used to be cheaper is like saying transportation used to be cheaper before airplanes. Of course, buying a horse is cheaper than buying a ticket on a jet, but the horse absolutely cannot cross the Atlantic Ocean in 6 hours. You can't put a horse in the sky.
That is a brilliant analogy. You can't expect the price of a horse when you are boarding a Boeing 747. The question isn't why modern medicine costs more than 1920s medicine. Capability costs money.
And we have incredible capabilities now.
We do. Today, we have neonatal intensive care units that save premature infants born at 24 weeks. We have precision oncology that targets specific genetic mutations in a tumor.
Right, joint replacements that get people walking again.
Exactly. All of that is incredibly resource intensive.
So the real question, the absolute core question of this whole deep dive, isn't why the medicine itself is expensive. It's why America decided to finance this incredibly complex, miraculous modern medicine in such a convoluted, improvised, and deeply frustrating way.
Exactly. And to understand that improvisation, we have to look at the foundation of the financing. We have to trace the three massive historical bargains that literally built the American healthcare structure.
All right, let's get into those bargains. Bargain number one is the birth of Blue Cross, Blue Shield, and the concept of prepaid care in the 1930s.
Yeah, so this was the first massive conceptual shift. Before the Great Depression, the transaction was linear. You got sick, you went to a hospital, and you paid the doctor directly out of your own pocket.
Simple enough.
But as hospitals became slightly more advanced and therefore more expensive to run, people realized that a sudden medical emergency could instantly bankrupt a family.
Which was happening a lot during the Depression, I imagine.
All the time. During the Depression, hospitals were going broke because nobody could pay their bills. So they came up with an idea, which was prepaid hospital coverage.
How did that work?
For a tiny amount each month, teachers in Dallas, Texas, for example, could prepay for up to 21 days of hospital care a year.
Oh, wow. So you pay a little bit up front continuously into a shared pool.
Right.
So if disaster strikes, you aren't completely ruined and the hospital knows it will actually get paid. I mean, it sounds incredibly humane, logical, and totally necessary.
It was incredibly humane, it stabilized families financially, and it stabilized hospital revenues so it could actually grow, keep the lights on, and invest in better technology.
But there's a catch.
Always.
Mm-hmm.
It introduced a massive permanent consequence to the American system, third-party payment.
This is the turning point where the whole psychology of the transaction shifts, isn't it?
Absolutely. Think about the car dealership analogy you used earlier. The moment you separate the person receiving the care, the patient from the entity actually paying for the care, the insurance pool, everything fundamentally changes.
Because you aren't paying the doctor directly anymore.
Right. You are no longer directly transacting with the provider. Suddenly, you need a massive apparatus of rules. You need someone to administer this giant pool of money.
Bureaucracy enters the chat.
Big time. You need actuaries to calculate risk, claims adjusters to process the paperwork, and most importantly, you need administrators to decide what legally counts as medical necessity.
So healthcare transformed overnight from a simple direct social exchange into a thick, bureaucratic, institutional economy.
Exactly. Which naturally leads us to bargain number 2.
And this is the one that always completely blows my mind. Employer-sponsored insurance and the tax exclusion.
It's a big one.
Because from a purely logical perspective, tying my literal health, survival, and access to a doctor to whether or not my employer's quarterly profits are up, I mean, that makes zero sense.
No, it doesn't.
If I lose my job, I lose my income and my healthcare on the exact same day. Why did we build it this way?
It makes absolutely no sense until you look at the specific historical crisis of World War II.
Okay, take us back.
So the United States was pouring all its industrial capacity into the war effort. To prevent runaway inflation, the federal government imposed strict wage and price controls. Employers were legally forbidden from raising hourly wages to attract workers to their factories.
So imagine you're a factory owner in 1943. You desperately need machinists to build airplane parts, but you can't offer them an extra 50 cents an hour because it's literally illegal. What do?
You have to find a substitute for cash. Employers started offering fringe benefits, specifically health insurance, as a legal recruiting tool to steal workers from competing factories.
I can't pay you more dollars per hour, but come work for me and I'll make sure your family's hospital bills are completely covered.
Exactly. It's a brilliant workaround.
But the war ended. Wage controls ended. Why did this system stick around and become the bedrock of American life?
Because of a monumental decision made by the IRS, which was later codified into law in 1954, the government decided to exclude employer contributions toward health coverage from a worker's taxable income.
Wait, let's make sure we totally understand this because it's massive.
It is.
If my boss gives me a $5,000 raise, the government taxes that money. But if my boss gives me $5,000 worth of health insurance, neither of us pays taxes on it.
Exactly. It is the defining feature of the American path. That single tax preference subsidized healthcare benefits far more generously than regular cash wages.
So everybody wanted the benefits instead of cash.
Right. It made rich, comprehensive employer plans incredibly attractive for both the union workers demanding them and the executives offering them. But the hidden structural consequences were profound and permanent.
Because we permanently tied health security to labor market status.
Yes. So if you are a freelancer, a part-time worker, or someone too sick to work, you are immediately locked out of the primary system of health security.
And beyond that individual level, it completely fragmented the national risk pool, right?
Completely. Insurance works best when everyone, young, old, healthy, sick, is in one giant pool to spread the risk. Instead, America built countless tiny, siloed pools.
Like every company has its own pool.
We have large group employer plans, small business plans, union Taft-Hartley plans. It fractured the entire structure of risk. It made keeping your insurance when you change jobs nearly impossible, and it multiplied the administrative differences across the whole country.
Employers basically became the default sponsors of the American social safety net without ever officially signing up for the job.
Exactly. They got stuck with it.
Okay, so that's the private side of the foundation. But what about the people left behind? The elderly who couldn't work anymore, and the poor?
That brings us to bargain number 3.
Medicare and Medicaid, created in 1965. And these are not just government side projects. They are the load-bearing walls of the entire American healthcare system.
Load-bearing walls is the perfect term. If employer insurance is the primary channel for the working and middle class, Medicare and Medicaid are the giant public pillars holding up the rest of the delivery system.
Because so much money flows through them.
Massive amounts. Without the cash flow from these two programs, much of the medical infrastructure in this country, especially rural hospitals and urban safety net clinics, would literally collapse within months.
Wow.
But what's fascinating is how completely different their underlying logics are.
Let's break that down, starting with Medicare.
So Medicare is a massive federal social insurance program. It essentially declares, as a society, that old age and certain severe disabilities carry medical risks that are simply too catastrophic and inevitable for the private market to handle alone.
And everyone pays into it.
Right. It is uniform, it is national, and it is tied to age and work history, not your current income. A retired janitor and a retired corporate lawyer both get Medicare when they turn 65.
But it's not a magical all-in-one blanket that covers everything seamlessly, is it?
No, and this is a harsh surprise for many people when they finally age into the system. Traditional Medicare is built from fragmented components.
Like the different parts.
Exactly. Part A covers the hospital and patient stays. Part B covers physician services and outpatient care. Then, decades later, we added Part D to cover prescription drugs.
And even then, there are gaps.
Huge gaps. Because traditional Medicare still leaves you with significant out-of-pocket costs, many people have to buy a private supplemental Medigap policy. So even our most famous, beloved public insurance program requires beneficiaries to navigate a complex maze of additional layers to be truly financially protected.
And then there's Medicaid, which is an entirely different animal.
Medicaid is a completely different beast. It is a welfare program, not a social insurance program. It is jointly financed by the federal government and the individual states, which means its rules, its generosity, and its political support vary wildly depending on which state you live in.
I want to dig into the financing of Medicaid because I've heard the term FMAP used before, and it seems to be the engine driving how this works. What exactly is FMAP?
FMAP stands for the Federal Medical Assistance Percentage. It is the formula the federal government uses to match what a state spends on Medicaid.
So it's a matching system.
Exactly. If a state is relatively wealthy, the federal government might match them dollar for dollar. But if a state is poorer, with a lower per capita income, the federal government might pay 70 or even 80 cents of every dollar spent on Medicaid in that state.
Oh, wow. So it strongly incentivizes states to expand their programs because for every dollar they put in, the federal government rains down free money into their local healthcare economy.
Exactly. It's a massive economic engine for the states.
Yeah.
And it is means-tested, meaning it is strictly for low-income populations, pregnant women, children, and people with certain severe disabilities.
But here is a truly mind-blowing detail for you listening right now. Medicaid isn't just poor people's doctor visits. Medicaid is actually the primary financier for nursing homes and long-term care in the United States.
This is a crucial, widely misunderstood fact. Medicare generally does not pay for long-term custodial care in a nursing home. It pays for short rehab stints after a hospital stay, but not years of living in a facility.
So what happens when people get old and need full-time care?
Well, people age, they develop dementia or physical frailties, they move into a nursing home, and they quickly spend down their life savings paying for it.
Because it's incredibly expensive.
It is. And once they are impoverished, Medicaid steps in and pays the bill. Medicaid is the financial backbone for the institutional care needs that arise when aging, disability, and poverty collide.
That makes total sense now.
This is exactly why the political battles over Medicaid are so incredibly fierce. When a governor is debating Medicaid cuts, they aren't just debating pediatric care for low-income families. They are debating the fundamental budgetary survival of their state's entire nursing home industry.
Which brings us to the payer mix hierarchy. Because once you have these fragmented pools of money, commercial employer insurance, Medicare and Medicaid hospitals and doctors naturally start looking at patients differently.
They absolutely do. Every hospital administrator, every clinic manager, every physician practice knows the hierarchy.
What's at the top?
Commercial employer insurance is at the top. It generally pays the highest, most profitable rates. Medicare is in the middle. It pays significantly less than commercial insurance, but it is highly reliable, the volume is massive, and the checks always clear.
And Medicaid.
Medicaid is at the bottom. It is essential, but it often pays the absolute lowest rates, sometimes less than the actual cost of providing the care. And then, of course, the uninsured create uncompensated care, which is a total financial loss.
So if you are a hospital administrator, you aren't just looking at a waiting room full of sick human beings. You are looking at a complex matrix of profit and loss based entirely on what kind of plastic card is sitting in each patient's wallet. Sadly, yes. This hierarchy dictates provider behavior at a geographic level. It explains why massive, gleaming hospital systems aggressively build new state-of-the-art facilities in affluent suburbs with high rates of commercial insurance.
Oh, the money.
Always. And it explains why safety net hospitals in poorer urban neighborhoods or rural areas where the payer mix is heavily tilted toward Medicaid and the uninsured are perpetually operating on razor-thin margins and constantly on the brink of financial collapse.
Okay, so we've mapped out the fragmented pools of money. We have employers, the government, and the patients themselves. This brings us to the institutions built to extract that money.
The cost machine.
Right. Why did prices absolutely explode over the last few decades?
Yeah.
There are 7 specific engines of inflation that drive this cost machine. Let's really dig into them.
Let's do it. Engine 1 is clinical success and technology. Like we discussed with the airplane analogy, modern medicine can do vastly more. But every time we invent a new MRI machine, a robotic surgical arm, or a targeted biologic drug, we add massive new capital costs to the system. Engine 2 is our aging demographic. The baby boomer generation is moving into their high utilization years, right?
Exactly. Older populations naturally consume exponentially more healthcare, more joint replacements, more chronic disease management, more cardiovascular care.
Engine 3 is simply unit price. We just pay more per unit of care than any other developed country.
By a lot. A hip replacement costs more here. A day in the hospital costs more here. A nurse's salary is higher here. An MRI scan costs more here. The volume of care we get isn't necessarily higher than in Europe, but the price tag on every single interaction is massively inflated.
Engine 4 is the sheer weight of administrative overhead. Because we build a system with thousands of different insurance plans, variable benefit designs, incredibly complex coding systems, and prior authorizations, we require millions of hours of human labor just to process the paperwork.
We literally pay an army of people to argue about money.
Engine 5 is our political refusal to explicitly ration care.
This is a big cultural difference. In countries with single-payer systems, a central government board might look at a new, marginally effective million-dollar drug and simply say, no, it's not cost-effective, we won't cover it.
But in America, we hate that idea.
We refuse to put hard, explicit caps on things. Because we won't ration explicitly, we ration implicitly through complexity, high prices, and deductibles.
Engine 6 is the financialization of care. Wall Street and private equity investors realize that healthcare generates massive, recession-proof, dependable cash flow.
Right, so you see the rise of organizations built purely to optimize billing codes, consolidate practices, and maximize revenue extraction, rather than focusing purely on clinical outcomes.
And finally, Engine 7 is our remarkably weak strategic investment in primary care and public health. We spend gargantuan sums of money on downstream rescue care in hospitals, putting in heart stents after a heart attack.
But we chronically underpay and under-resource the primary care doctors who could have spent time managing the patient's blood pressure 10 years earlier to prevent the heart attack entirely.
I want to zero in on hospitals because they are really the financial core of this entire system. They aren't just buildings with beds where sick people go to get better anymore. They are described as regional platforms and payer mix strategists.
Yeah, if you want to understand where the massive rivers of money pool in American healthcare, look at the hospital. They house acute care, highly specialized surgeons, advanced imaging, and emergency rooms.
And they've gotten huge.
Massive. In many metropolitan areas, they have consolidated to the point where they are completely indispensable monopolies. An insurance company literally cannot sell a viable health plan in that city if they don't include the dominant local hospital system in their network.
Because if the main hospital isn't in your network, no employer will buy your insurance plan for their employees, which gives the hospital massive, almost absolute leverage to demand whatever prices they want.
Exactly.
But here is the massive aha moment for me regarding hospitals. Slate of service pricing. This mechanic completely blew my mind. Walk us through exactly how this works.
This is one of the most consequential, invisible mechanics driving up costs in the entire system. Imagine you have a strange rash, and you go to your independent local dermatologist for a checkup.
Okay.
The bill is, say, $200. Your insurance pays a portion, you pay your copay. Everyone is happy. 6 months later, you go to the exact same doctor in the exact same building for a follow-up checkup on the exact same rash.
Right.
But this time, the bill comes in at $600, and it includes a massive new line item called a facility fee. What happened?
Wait, the clinical care didn't change at all. The doctor is the same, the room is the same, the stethoscope is the same.
Not one clinical element changed. What happened is that between your first visit and your second visit, a massive regional hospital system bought that independent dermatology practice.
Sneaky.
Legally, they have now changed the classification of that office on paper from an independent physician office to an outpatient hospital facility.
Just on paper.
It's just on paper because of that simple legal reclassification.
Yeah.
Medicare and private insurers allow them to bill at a vastly higher rate for the exact same service, just because the hospital's logo is now on the door.
That is absurd. The care didn't change at all. The legal umbrella did. It's pure revenue optimization. They are buying up independent practices specifically to slap a facility fee on them.
Exactly right.
And this completely alters the landscape for the doctors themselves, which leads to our next point, physicians and the shift in power. We all lament the loss of the independent family doctor, that, Marcus Welby figure who knew your whole family, delivered your kids, and spent an hour talking to you.
The economic reality is that the payment hierarchy we discussed earlier heavily rewards highly procedural care, over cognitive care.
Cognitive meaning just thinking and talking?
Right, which means continuity, relationship building, and conversation. The system operates on a coding metric called RVUs, or relative value units.
How do those work?
Well, if a system pays wildly more RVUs for a surgeon performing a knee replacement or a cardiologist placing a stent than it does for a primary care doctor spending 45 minutes talking to a patient about managing their diabetes diet, the entire medical workforce is inevitably going to tilt toward the procedures.
Follow the incentives. Specialization becomes incredibly lucrative, and independent primary care becomes financially unsustainable due to the massive overhead of hiring staff just to deal with all these insurance companies and prior authorizations. So what happens? Doctors are forced to become employees.
They trade their independence and autonomy for stability. They join corporate physician groups or become direct employees of the massive hospital systems.
And once they are employees,
Once they are employees, they are judged by a completely new set of corporate metrics: patient throughput, coding optimization, and keeping referrals strictly inside the hospital's network.
and the patient feels that.
The patient acutely feels this shift. It manifests as 15-minute appointments, doctors staring at a computer screen, typing furiously instead of looking at you, and a total loss of that deep personal continuity. You are no longer a patient in a relationship. You are interacting with a node inside a massive enterprise.
Here is where it gets really interesting, though. We have hospitals consolidating to optimize revenue. We have doctors specializing in speeding up to maximize their billing. Someone in this massive economy has to try and stop the bleeding, right? Someone has to say no, enter the insurers and managed care.
Yeah, this raises a profoundly uncomfortable question for Americans. If we as a society absolutely refuse to let the government uniformly set medical prices the way France or Japan does, who enforces cost discipline?
Who tells the hospital they can't charge $1,000 for a bag of saline?
Exactly. In America, that dirty work falls to the private insurance companies.
And we all absolutely hate insurance companies. We hate the denials, the paperwork, the confusing networks.
But from a purely economic standpoint, they're doing exactly what the structural design of the system forces them to do.
Which is what?
Because the underlying cost of care generated by hospitals and pharma is exploding, if insurers just passively paid every bill at the hospital's asking price, your monthly premium would skyrocket so fast it would bankrupt you and your employer in a year.
So they have to push back?
They have to. To control the costs, insurers have to build managed care tools. They use prior authorization to force doctors to prove a scam is necessary. They use step therapy to force you to try a cheap drug before they'll pay for the expensive one.
And the narrow networks.
Right. They build narrow networks where you can only see certain doctors who have agreed to lower rates.
So they are the ultimate cost disciplinarians of the American market. But because their tools are opaque, restrictive, and deeply annoying to use, they become the easiest villain for the public to hate. But there is a massive trap here, isn't there? The premium trap.
Yes. Despite all their managed care tools, the underlying costs of medical care just keep rising faster than inflation. So employers and insurers had to make a very difficult choice.
What choice?
Take a look at your pay stub next week. You might feel like you haven't gotten a meaningful raise in 5 years. But your employer is actually spending $5,000 more on your compensation than they used to. It's just entirely being swallowed by your health premium increase.
Oh, man.
To keep the monthly premium from becoming so high that employees completely revolted, they shifted the burden to the patient at the point of care.
By jacking up the deductibles.
Exactly. You still have your insurance card in your wallet. Your monthly premium is somewhat contained, but now you have a $3,000, $4,000, or $5,000 deductible.
Which means you're basically uninsured for everyday stuff.
You are effectively underinsured. You are paying a massive premium every single month for the privilege of still being absolutely terrified of actually going to the doctor, because you know you'll have to pay thousands of dollars out of your own pocket before the insurance company pays a single dime.
So we've seen how hospitals act as regional monopolies to extract those employer dollars, and how insurers try to fight back by squeezing the patient. But there is a second massive leak in the boat that operates completely outside the hospital walls, and it's happening right at your local pharmacy counter.
The pharmacy labyrinth.
Exactly, Section 4. If hospital billing is the financial core of this system, the prescription drug market is where the system's absolute absurdity becomes perfectly visible to the consumer.
And we have to start by clarifying something very important. The generic drug system in America actually works remarkably well.
Really?
Yeah, for small molecule generic drugs, think of basic chemical recipes like aspirin or generic blood pressure meds where robust competition exists. Prices are driven down sharply. The crisis of cost is happening in the protected branded therapies and biologics.
Wait, before you go on, what exactly is a biologic? How is it different from a small molecule drug?
It's a great question. A small molecule drug is like baking a cake. It's a specific chemical formula. Once the patent expires, any competitor can look at the recipe, mix the chemicals in a vat, and produce an identical generic copy very cheaply.
Okay, that makes sense.
A biologic drug, on the other hand, is like raising a prize-winning racehorse. It is a highly complex, large molecule derived from living cells. Drugs like Humira for rheumatoid arthritis or advanced cancer immunotherapies.
So you can't just copy it.
Right, because they are grown in living cells, you can't just copy a chemical recipe. You have to replicate the entire biological manufacturing process, which makes them incredibly expensive to develop and very difficult for competitors to copy.
So the manufacturers of these new complex drugs, these biologics, exploit what are called launch windows. They build massive patent thickets, tweaking the delivery device or slightly altering the formula to intentionally insulate themselves from any generic competition for as long as humanly possible. They are maximizing their monopoly pricing power.
Because they know the moment true competition enters the market, their revenue drops off a cliff. So they fight fiercely in the courts and at the patent office to protect their monopolies.
But this brings up a huge, glaring question. If my employer pays for my health plan and the drug maker makes the pill, who is deciding that my specific pill suddenly costs $500 today when it cost $50 last year?
Enter the most confusing, opaque power center in all of American healthcare, the pharmacy benefit manager, or PBM.
Let's shine a massive spotlight on PBMs. Because nobody knows what they are, they don't manufacture any drugs, they don't treat any patients, but they control billions of dollars. So the PBM is basically a toll booth operator on a highway, but they also own the highway, and they demand a massive cut from Ford and Toyota just to let their specific cars drive on it. Originally, though, they were just hired to do basic administrative work, right?
Yes, their origin story is completely rational. As prescription drug benefits became incredibly complex, with thousands of new drugs and thousands of local pharmacies, employers and insurers needed a specialized intermediary just to process the sheer volume of claims and organize a network of pharmacies.
Just a paperwork middleman.
It was a rational solution to a coordination problem. But once you insert an intermediary at the strategic choke point of a massive money flow, they don't stay a neutral administrator for long.
They became massive, highly consolidated gatekeepers.
They control the formulary. The formulary is the menu of drugs your insurance actually covers. They control which tier a drug sits on, whether you pay a $10 copay or a $100 copay. And they use that immense consolidated leverage to extract massive financial concessions from both the drug manufacturers and the pharmacies.
Which leads to the rebate game, and this is the concept that is truly going to blow the listener's mind. Please explain the difference between the list price, also known as the WAC, and the net price.
This is where the logic of American drug pricing becomes publicly absurd. The list price, or the wholesale acquisition cost, is the official sticker price the manufacturer sets.
The MSRP, basically.
Right. It's the number you see in the news when a drug launches. But the PBM goes to the manufacturer behind closed doors and says, if you want your drug on our preferred formulary tier so our 50 million members will use it, you have to give us a massive secret rebate.
Okay.
The net price is what the plan actually ends up paying after they get that secret rebate back from the manufacturer.
So let me see if I have this PBM math right. If I'm a drug maker, I actually want to artificially raise my list price because it gives me a bigger margin to offer as a secret rebate to the PBM to win their favor.
You're exactly right on the incentive. It functions as a negotiated discount. But the behavioral result is exactly what you just described. It creates a perverse incentive for manufacturers to inflate the list price.
Can you give an example?
Let's look at how it plays out in reality. A drug manufacturer might set an incredibly high list price, say $1,000 for a month's supply, but offer a massive $600 rebate to the PBM. So the true net cost of the health plan is $400.
Okay.
Meanwhile, a competing drug manufacturer might try to be transparent. They offer a simple list price of $500 with no rebate.
Common sense dictates that the $500 drug should win the formulary placement because it's overall cheaper.
But in the American system, the $1,000 drug often wins. Why? Because the PBM and the employer plan sponsor want that massive $600 rebate flowing back to them. They choose the drug with the artificially inflated list price because the rebate acts as a revenue stream for the PBM.
And here is where the sick patient gets utterly crushed by the math. Because I, the patient, have a high deductible to meet. Or my plan says I have to pay 20% coinsurance for specialty drugs. And my 20% coinsurance is calculated based on the artificially inflated $1,000 list price, not the secret $400 net price.
Exactly. You buy the pill. The PBM and the insurer win the rebate game behind the scenes, but the sick person standing at the pharmacy counter takes the full financial brunt of the inflated list price.
That is just brutal.
The transaction structure is financially highly optimized for the payer and deeply, deeply punitive for the patient. As the research shows, the sick person at the counter is the last participant to benefit from the savings story told by everyone else in the supply chain.
It is enraging. And it gets worse because PBMs also engage in something called spread pricing. Walk us through a concrete transaction of how spread pricing works.
Spread pricing is another layer of opacity. You go to your local independent pharmacy to pick up a generic drug. The PBM manages this transaction. The PBM tells your employer's health plan, this drug costs $100. So your employer pays the PBM $100.
Got it.
But then the PBM turns around to the local pharmacy and says, we are only reimbursing you $80 for dispensing this drug.
Yeah.
The PBM pockets a $20 difference. That is the spread. They are charging the plan more than they are paying the pharmacy and keeping the margin.
So the employer is overpaying, the pharmacy is getting squeezed, and the PBM takes a cut of every single pill passed across the counter. It's all part of what analysts call the machinery of friction. We are dealing with sheer administrative weight coding, prior authorization, denials, and pharmacy benefit managers all fighting over margins.
Friction is how the system exerts power. We talked about how insurers use prior authorization to control costs. But the reality is, this creates an environment where doctors have to hire entire teams of administrative staff just to argue with the insurance company's team of administrative staff over whether a medically necessary treatment will actually be approved.
We are literally spending billions of dollars paying people to fight with other people about money, which exhausts both the doctor trying to provide care and the patient trying to receive it.
And it deeply degrades the quality of service. The patient experiences the health system as suspicious, fragmented, and profoundly impersonal.
Okay, so we've mapped the plumbing. We understand the historical foundations, the hospital monopolies exploiting site of service fees, the insurance deductible traps, and the PBM toll booths. Which brings us to the modern settlement. What has the government actually done about all this in recent memory? We have to talk about the Affordable Care Act, Obamacare.
Right. The Affordable Care Act is often entirely misunderstood by both its biggest fans and its harshest critics. Analytically, it is best understood as a massive repair law, not a replacement of the American system.
Let's do an ELI 5 on that mechanical distinction. Why was it a repair and not a replacement?
Before the ACA passed in 2010, the individual insurance market for people who didn't get insurance through a job or the government was genuinely cruel. If you had a pre-existing condition, asthma, cancer, diabetes, even a previous pregnancy, an insurance company could simply deny you coverage entirely or charge you wildly exorbitant rates.
Because you were considered too high risk.
Exactly. Millions of people were completely uninsured simply because they didn't have a job that offered benefits and they were too sick for the private market to touch them. The ACA fixed that cruelty through two major mechanisms, guaranteed issue and community rating.
What do those mean?
It meant insurers legally had to cover you regardless of your health history, and they couldn't charge you more just because you were sick. It also created massive tax subsidies to help lower-income people afford the premiums, and it expanded Medicaid for the poorest Americans.
So it was a massive moral achievement. It brought millions of people into the tent and saved lives.
Unquestionably. But structurally, it left the core cost machine completely untouched. Adding subsidies to help people afford premiums does absolutely nothing to change the hospital's chargemaster rates.
It didn't fix the root problem.
The ACA didn't stop hospital consolidation. It didn't dismantle the PBM opacity or the rebate game. It didn't stop the rise of massive employer deductibles. It basically took the existing, highly fragmented, hyper-expensive delivery system and just added another subsidized financial layer on top of it to bring more people in. It improved access dramatically, but it failed to tame the underlying unit cost of the medical care itself.
And this leads to the fragility of the individual market today. When you go onto the ACA exchange to buy your own insurance, you suddenly realize that health insurance in America is not a national product.
No, it is intensely hyperlocal. You aren't buying a national policy that works everywhere. You are buying a state-regulated plan, deeply tied to a very specific local network of hospital monopolies and local physician groups.
That's why networks are so tricky.
That's why your silver plan in Dallas is completely useless if you move to Denver or get sick while visiting family in Ohio. It exposes how fractured the geography of American healthcare truly is.
Let's make this incredibly concrete for the listener. We've talked about all these macro forces. Let's walk through an actual medical bill step by step based on how all these mechanics collide. Walk us through a trip to the ER for severe abdominal pain.
Let's trace the sequence of the transaction. You wake up in agony, you go to an in-network emergency room, you get a CT scan, some blood work, and a doctor evaluates you. Thankfully, it's not appendicitis, just a severe stomach bug. You go home.
Phew, but then...
A month later, the paperwork arrives. Step 1, the hospital generates the gross charge. This is based on their internal, highly inflated charge master. Let's say it's an $18,000 sticker price for the visit.
18 grand for a stomach bug, which is a terrifying number to see on a piece of paper.
It is terrifying, but it's largely a fictional number. Step 2 is the network allowed amount. Because the hospital is in-network, your insurance company's previously negotiated contract kicks in.
The insurer steps in.
The insurer looks at that $18,000 charge and says, no, our contracted allowed amount for this specific level of ER episode is only $7,200. The hospital legally has to write off the difference.
Okay, so the price dropped to $7,200, but my insurance doesn't just cut a check for that amount, right?
Not even close. Step 3 is the deductible. Let's say your employer plan has a $2,500 deductible, and you haven't used any of it yet this year. The insurance company dictates that you owe the first $2,500 of that allowed amount entirely out of your own pocket.
Boom, $2,500 gone from my checking account.
Now there's $4,700 left of the allowed amount. Step 4 is coinsurance. Your plan design says that after the deductible, you pay 20% of the remaining balance and the insurer pays 80%.
Do the math for me.
So you owe 20% of $4,700, which is another $940 in coinsurance.
So I pay my $2,500 deductible plus my $940 coinsurance. I'm writing a check to the hospital for $3,440.
Exactly. And the profound realization here, the reason patients feel so deeply besieged and angry, is that a medical bill isn't a price you agreed to beforehand, like buying a burger or a car.
You had no idea what it would cost.
You didn't know the hospital's charge master. You didn't know the insurer's secret negotiated allowed amount. You didn't know how the specific billing codes would fall. And you couldn't calculate your coinsurance. The bill is the end result of a massive, invisible contractual battle between giant institutions. The bill you receive in the mail is not a price. It is a verdict.
A verdict. That gives me absolute chills. And navigating this landscape is getting even harder because the lines between public and private are completely blurring. We are seeing the massive rise of privatized public care.
Yes. Through programs like Medicare Advantage and Medicaid managed care, we are now funneling hundreds of billions of taxpayer dollars directly to private, for-profit insurance companies to manage the care of public beneficiaries.
Wait, really?
Yeah, the state finances it, but the private health plan manages it, bringing all the restrictive tools of private managed care, prior authorizations, narrow networks, aggressive coding optimizations into the public sphere.
And we absolutely cannot ignore the role of private equity in all of this. We hear a lot of horror stories in the news about PE firms buying up nursing homes, independent dermatology practices, or emergency room staffing groups. What is actually happening there?
It's important to be highly nuanced here. Private equity did not break the American healthcare system. The structural flaws we've discussed have been there for decades.
Right.
But private equity is a financial vehicle perfectly designed to exploit the specific system we built. They look for highly fragmented sectors like anesthesiology groups or autism clinics where they can aggressively roll them up, consolidate ownership, squeeze staffing levels, optimize billing codes to extract higher RVUs, and jack up prices using their newly acquired local monopoly power.
They just optimize the extraction.
They are simply pressing the existing flawed incentives of the system harder and faster than anyone else. They're the apex predators of an ecosystem that inherently rewards extraction.
So we've mapped the entire plumbing of the house. We understand the historical foundations, the monopolies, the hidden rebates, and the crushing deductibles. Which brings us to present-day consequences and what actually needs to change. What does it actually feel like to live in this house we built, and how do we remodel it?
Well, the universal feeling among both patients and doctors is profound exhaustion and frustration.
Right. It's the ultimate paradox of modern life. We have the most advanced, miraculous medicine in human history. We can literally cure hepatitis C with a pill. We can do precision gene therapy for rare childhood diseases. So, why is actually going to the doctor to get a weird lump checked out feel like a hostile trip to the DMV? Why do I feel like a widget on an industrial assembly line?
Because that clinical progress is trapped inside institutions that are completely optimized for financial extraction, coding compliance, and liability management. The delivery system prioritizes revenue cycle management over the human experience.
The paperwork always comes first.
The human surplus of medicine, the time, the empathy, the trust, the continuity of a doctor actually sitting down and getting to know you, has been systematically replaced by digital patient portals, throughput metrics, rigid drop-down menus and electronic health records, and centralized call centers. The richest healthcare system in the history of the world routinely makes sick people feel like they are administrative burdens.
And it forces us to talk about the R word, rationing. Politicians love to stand up at podiums during debates and loudly proclaim, America does not ration healthcare. We are a free market. Socialized medicine relies on rationing.
And we have to push back on that claim incredibly hard based on the evidence.
Yeah.
We absolutely unequivocally ration care in the United States. We just lie to ourselves about how we do it.
So if a government board isn't doing it, how do we ration it?
Other countries might ration by having a government agency set explicit limits on which drugs are covered, or by having longer wait times for elective surgeries. We ration through our wallets and our patients.
Oh, so?
We ration via massive deductibles that force a middle-class family to skip necessary diagnostic tests because they simply can't afford the out-of-pocket hit. We ration via narrow insurance networks that restrict who you are legally allowed to see. We ration via prior authorizations that delay critical treatments for weeks while clerks argue over paperwork.
And geography, too, right?
Exactly. We ration geography when a rural hospital closes because its local payer mix had too much Medicaid and not enough highly profitable commercial insurance to keep the lights on.
So if you are staying in a miserable job that you hate purely because you are terrified of losing your employer's health insurance, you are experiencing the American form of rationing. We just use bureaucratic friction, geographic inequality, and high prices to do the rationing for us.
Exactly. It is unequal, it is deeply confusing, and it is highly punitive to the individual sick person who has the least amount of power in the transaction.
So how do we actually fix it? What are the structural changes required? The research lays out 7 essential reforms, not symbolic political fights, not just tweaking the edges, but deep structural changes. Let's really debate and explore these. Reform 1, break provider market power.
We have to aggressively enforce site-neutral payment. A standard doctor's visit or a basic imaging scan should cost the exact same amount of money, whether the practice is fiercely independent or owned by a massive multi-billion-dollar hospital system. We have to stop legally rewarding ownership arbitrage and facility fees that add zero clinical value.
Reform 2, redesign drug payments.
We have to kill the PBM rebate game. The opacity has to end. Patient cost sharing at the pharmacy counter must be based on the true, negotiated net cost of the drug, not an artificially inflated list price designed solely to generate secret kickbacks from middlemen.
Reform 3, confront underinsurance.
Having a piece of plastic insurance card in your wallet is not true coverage if the $5,000 deductible bankrupts your family before you can even use it. We have to legally redefine coverage as usable, actual financial protection, not just nominal enrollment in a high-deductible plan.
Reform 4, simplify administration.
We must standardize billing and coding rules across the entire board. Every insurer uses different forms, different portals, and different rules for prior authorization. The sheer weight of this administrative friction is burning out brilliant doctors and making patients miserable. We need a centralized, standardized clearinghouse for medical claims.
Reform 5, invest in primary care infrastructure.
We need to radically change the payment hierarchy to make longitudinal relationship-based primary care financially viable and highly attractive to young medical students. We have to pay for prevention, conversation, and chronic disease management, instead of only heavily rewarding downstream procedural intensity and surgeries.
Reform 6, make the government act like a confident purchaser.
Between Medicare, Medicaid, the VA, and federal employee benefits, the government is the largest purchaser of healthcare on Earth. but it often acts like a passive price taker. The government needs to use its massive consolidated leverage to explicitly shape system-wide prices and incentives, rather than just blindly paying whatever the fragmented commercial market demands.
And finally, Reform 7. Be honest about rationing and trade-offs.
We have to maturely admit that highly advanced, miraculous modern medicine will never be cheap, and every health system on the planet has limits. We need to make our societal trade-offs explicit, democratic, and humane, rather than hiding them behind opaque deductibles, complex paperwork, and GoFundMe campaigns.
So what does this all mean for the listener if we synthesize everything we've unpacked today? American healthcare is clearly not a clean, free market. You can't shop around for an ER while having a heart attack. And it is clearly not a clean, unified public system like the NHS in the UK.
Right, it's neither.
It is a messy, wildly expensive, chaotic hybrid patched together over a century of historical accidents, wartime wage controls, and intense political compromises. We built the most advanced medical capability in human history on top of a highly fragmented financing system, and then we layered massive administrative control on top of that fragmentation instead of actually simplifying it.
And it survives because it is a system of immense capability. It performs literal miracles every single day. Doctors and nurses work tirelessly to save lives. But it delivers those miracles through a financial and administrative structure that imposes chronic stress, anxiety, and deep distrust on everyone who touches it.
Which leaves us with a truly provocative thought to end on, building directly on those macroeconomic numbers we started with. Healthcare is 18% of the entire U.S. economy. Hospitals are often the single largest employers in their respective American cities.
This is the terrifying, unspoken paradox of healthcare reform. If we actually succeed in fixing the cost machine, if we successfully slash hospital prices, eliminate the millions of jobs tied to administrative bloat and billing, and drastically rein in prescription drug spending, we aren't just lowering your monthly premium.
We are shrinking the economy.
We are intentionally slashing the revenues of our own local economies.
Yeah.
We are talking about mass layoffs in hospital billing departments, shrinking budgets for local clinics, and a noticeable contraction of the national GDP. Are we as a country actually prepared to inflict a massive economic contraction on our own hometowns in order to finally get an affordable medical bill?
It is a staggering, deeply uncomfortable trade-off to consider. So the next time you walk into your kitchen and look down at that confusing, crossed-out, completely baffling medical bill sitting on your counter, don't just look at it as a math error or a computer glitch.
No, it's much more than that.
Look at it as a historical document. You are holding 80 years of political compromises, tax loopholes, corporate strategies, and bureaucratic friction in your hands, all culminating in a verdict demanding your money. Thanks for joining us on this deep dive.